Good afternoon. My topic is slightly overlapping with Dr. Biswas. I'll just highlight a few points which I want to add. So immunosuppression, as we know, is all with steroids. We tend to taper too early. We tend to undertreat. But remember, we have three drugs: the steroids, the classical immunosuppressive drugs, and the biologics. So what we have learned from oncology and rheumatology is that steroids, we do an induction phase, and then we go into the remission phase, low dose. In biologics also, we go into induction phase and we go to, but the IMTs, the other ones, we start with a lower dose, and then as the tolerance is there, it is basically for maintenance, and then we increase. So we need to remember that the IMTs are not going to be more effective than the steroid. They're just a replacement to the steroids. And every time we start a IMT in India, we always worried about TB, whether it's infection. So what we do is I do all patients with a start, do a CT scan chest, and the patient is strongly MON2 positive. I even go for a PET scan. I found lymph nodes in the axilla, which would have missed with the CT chest. So why do we need to treat? Majority of time what you see a patient is who's been gone through multiple episodes of uveitis, had 6 weeks of steroids, and then recurrence after a year. But on a long term, they have complications like cataract, glaucoma, maculopathy. So what we have learned over the period is, from the rheumatologists, full remission. Do not believe in a simmering uveitis. Kaplan taught us 6-12 is fine, but I don't agree with that now. We want 6-6 in intermediate uveitis. So this is the article in IGO which we all published during the lockdown. So when do we start? So for me, every patient of intermediate posterior uveitis, I need to start IMT. I look for exceptions where not to start. But what we are taught generally is, these are the exceptions when you start. But if you think in your mind that I have to start everybody and find exclusions, so who is likely to have a requirement? Those with the initial vision of less than 6/60, who have a retina, choroid, or macular involvement, who have recurrent disease, bilateral sight threatening. All children require IMT. None are going to be resolved with just oral steroids. And in children, if you have cataract, synechiae, BSK, hypotony, it means it's a chronic disease. And in those who have intolerance, those patients who do not respond to steroid are unlikely to respond to IMT because IMTs are lesser effective than steroids. There are certain diseases which you know are going to last long. Behçet's, Wegener's, you will start IMT on almost within early days. So classical teaching is in 3-4 weeks, if you are not less to 30 milligram and the disease is active at 3rd or 4th week, think this patient requires IMT. Or when it comes down to 10 milligram, you have a recurrence. So start with it. All posterior uveitis are chronic, and then you will be able to treat it better. There are systemic diseases which require IMT and biologicals. So in these diseases, when you have a systemic disease, you need to follow the rheumatologist. So now what happens is that when you taper the steroids and you start the IMT late, there's a phase where the effect goes away. And you start thinking, oh, is it infection? Is it TB? Is it not effective? So if you do not start the IMT at the right time, there will be a phase at 3 months where the disease will come back. So you have to start within the first one, think that, yes, this is the time for me to start. So how did it all start? So the study has come from 2009, the SIDE trial. So we have these 4 drugs: azathioprine, methotrexate, MMFs, and cyclosporin. Just give me a second. Are they efficacious? No. They only work in 60 to 70% of patients. And that also we are able to reduce the steroids only to 10 milligram. So you have a study which says 10 years, 15 years ago, that 30% of your patients are not going to be controlled and will require biologics, or you will start putting implants in them. I'm sorry. So if you have a patient with cataract in a child or has glaucoma, you will start drugs earlier. But conventional immunosuppression is only going to be effective in 50%. So the MUST trial which came out, which compared the steroid implants with the IMT. Unfortunately, we have no prospective randomized trial to say which IMT is superior to the other, except one study which from Madurai which says that MMF is equivalent to methotrexate, but the methotrexate was given orally. So we don't know which drug is. Your experience, you will have to learn which one is better in your setting, which you can do. But this MUST trial initially said, oh no, the steroid implant is better. But at 7 years, they found out, no, it's actually the IMT which is superior because you don't have fluctuations. You don't have times where you have an active disease. When you give an implant, you tend to not repeat until there's an active disease again. So you tend to miss out the phases when the disease is active. So in the long term, they found at 7 years. But everybody had an apprehension that these drugs cause cancer. So over the last side trial, other retrospective trials have come that the risk of cancer is not higher in patients who use IMT. So this has removed the fear from the ophthalmologist's mind that we use these drugs and we may have to have a risk of cancer. So we have the commonest being methotrexate. Remember, pregnancy is the issue. Sperm, also even males have to use contraception. Nausea is a big irritating. The liver enzymes go up till 3 times acceptable. But remember, it really creates a nausea and depression on the day of the week which do. And when you go beyond 15 milligrams, the absorption goes down. So you have to use subcutaneous doses. So it is the easiest to monitor, but the patient nausea, you have to stop it in about 1/3 patients. Azathioprine is really effective. I feel it is the best, but monitoring these patients with low CBC, I've also had patients who had bone marrow suppression. We say TPMT test may predict, but no, you can still have suppression even if the patient is TPMT negative. MMF is the costlier one, used more for transplant patient, but yes, it's safer. But both mycophenolate and methotrexate cannot be used in pregnancy. Tacrolimus and cyclosporine are less used. They are less effective. You can use it as a combination. Now the question is, I have a patient who doesn't get treated with methotrexate, has active. Can I combine another drug? Yes, you can combine methotrexate with MMF. You can combine methotrexate with cyclosporine, but you cannot combine methotrexate and azathioprine. It becomes too toxic. So if the patient can't jump to biologic cost, so you can do combination. So we can use combination of 2 drugs, give steroid drops less than 2, give low dose steroids. You can use combination to treat the patient. So what are the ones available in India? So we have basically infliximab and adalimumab available in India. Infliximab is IV infusion, and adalimumab is the only one which has a prospective randomized trial. So everybody use adalimumab. We have the biosimilar in India. We don't have the original drug, but it works wonders. About 3 companies which make it, all are effective. Now, we are told that macular edema doesn't respond to anti-inflammatory. Yes, but macular edema by itself is not an emergency. You can wait a month or 2 until there are cystic changes or atrophy going in. You can take your own time. You can have. I have a patient of sarcoidosis who was advised Ozurdex. I gave the patient methotrexate. The edema disappeared after 3 months. So CME is never an emergency. So tocilizumab should be used only when it is not improving over a long time. JAK, the small inhibitors, don't work as well. They work at multiple levels. The risk of herpes is there. In adults, the risk of vascular occlusion is there. So I find I've been using ADA for 10 years. ADA to be more effective than tocilizumab. But when the patient cost factor is there, you can use those drugs. Rituximab, I use for orbital inflammatory disease and scleritis works better. The only problem is that if you give rituximab, you cannot add another drug for the next 3-6 months. It hits the B cell so badly that you cannot use another drug. While in ADA, if you try the ADA first and then go to rituximab, you have a chance to stop the rituximab. So before biologicals, yes, vaccine, especially in IMTs, vaccinate the children and the adults. When to start? Should we first wait 3 to 6 months with conventional IMT, then start to biologicals? But if it's side-threatening, if the child comes with cataract and glaucoma, I would straight away start biologicals. I don't have time for it to prevent the cataract progressing. What does it cause? It causes ANA positivity, it causes skin lesion sarcoidosis, it causes TB, demyelinating disease is a contraindication, and a theoretical risk of cancer. So TNF, higher risk. Yes, can I give TNF to a serpiginous like choroiditis? If you have treated it, yes, I have given patient ADA who have serpiginous choroiditis after they have resolved. How do I monitor? Vision plus the imaging. Sometimes you may have a clinical picture where the disease looks resolved, but we do a FAO ICG, the activity is there. So always before you stop the IMTs, remember you need full remission. Do not stop a patient who is on a smoldering disease which is not clinically active, but is active on imaging. So success is when you have a drug-induced remission, the cells are gone, there is no activity on the imaging, and at least 2 years If you have taken 2 years to control, keep 2 years at least for it to be tapered. And sometimes for those who have chronic, I have patients on 10 years of biologics. So sometimes they never go into remission. Biologicals do not cause remission. And even in the psychomotor trial, 1/3 of the children came back with uveitis. So once you put a patient on biological, don't tell them you're going to have remission. You just control the disease. Thank you. In STEP, you don't need to go STEP. You can jump one step from steroid to biologicals or IMT. Thank you so much.
Thanks, Dr.